and thank you for joining us today. And I hope you'll find an interesting and informative discussion. We are talking, my name is Professor Peter Nash from the Griffith University in Brisbane. And today we're very fortunate to have a very busy man, Professor of Infectious Diseases, Public Health, Preventative Medicine and Ophthalmology from the Oregon Health and Science University in the US, Professor Kevin Winthrop, who's one of the world's leading ID physicians. And he is also a steering committee member of the CSF Forum. And today we're talking about his paper published towards the end of last year in Rheumatology Therapy on the clinical management of herpes zoster in patients with RA and PSA receiving TOFA therapy. And this is an accumulation of 21 RA clinical trials and 3 PSA trials. Thank you and welcome, and thanks for joining us, Kevin.
Yeah, thanks, Peter. Great to see you.
All right, so let's talk a little bit about how you did this study with all those different papers and as a post hoc analysis.
Yeah, I think it was some of us sitting around the table thinking, boy, maybe we need to do a final look at zoster with TOFA across indications over, many years. And, I think at that point there'd been, approval in multiple indications and, development programs in multiple indications. And so, the idea was to look at people with arthritis. This is RA and PSA. And of course, there's lots of RA studies here. I think you mentioned 21 kind of phase 2, phase 3, 3/4 LTE studies, and then 3 PSA studies also from the clinical trial development program. So these were all, again, phase 2 through 4 studies, clinical trials. We had a lot of patients here to look at over a long time period. So that was the nature of the beast.
Okay, and you've selected TOFA, but do you really think there'll be any difference between TOFA and the other JAKs? Maybe Filgo, but UPA and Barry about the same, or do you think it's more likely to be an issue with one JAK compared to another JAK?
Yeah, so I mean, you just summarized it well, I think. I mean, we obviously just looked at TOFA because this was TOFA clinical development program data. But as you mentioned, we've seen the same thing in the development programs for individual disease indications for all the JAKs, except maybe Filgo. And again, of course, Filgo is done much later in time. A little bit different regions of enrollment too in their phase 2 program, although their phase 3 program was very similar. So we'll just have to see where that goes. I think it's an open question that perhaps Filgo is less risky than the others, but we'll have to see.
Okay, so you've got data on something like 7,000 RA patients. I was interested to see that 0 vaccination in this collection of patients. Is that what's happening in the US now?
Yeah, I mean, unfortunately, I think in most of these studies, vaccination history wasn't collected. And some of that was just because way back when in the early studies, we didn't even know we should do it. And then of course, later we wanted to do it, but maybe hadn't gotten it implemented in the protocol in time. And then, it was very clear from other studies that very few people had been vaccinated anyway. And in a lot of these countries where these patients are being enrolled, there isn't even access to vaccination. So my suspicion would be that very few people in this experience have been vaccinated. Now, I do know the vaccine rates are up here, in the US the last, 5 years. I forget when Jeff Curtis, I did a look 6 or 8 years ago, and it was like 4% of patients with RA or who are eligible had been vaccinated. Now I do know it's much higher, and I think it's probably more like 20 or 25% now, but that's without a formal look at the issue, but it is an unmet need still, certainly.
Okay, and so some of the numbers, you'd look at 7,000 RA patients, 11% got zoster. That's about 3.6 per 100 patient years, which is what you've published previously around the planet. But only 2% had a history of past zoster. Do you think it's worth asking patients about a history of past zoster, and would it change the way we use vaccination or different therapies? Is a history helpful?
Yeah, it's a good question. I mean, what was interesting, I think, preface my answer would be that there are these people in this experience that develop recurrent events. So it was highest in RA. I think it was about 8% of individuals actually had more than one zoster event.
That
and I think
sounds bad, Kevin. That
what's
sounds a
that?
lot. That sounds
Yeah,
a lot to get recurrent zoster.
yeah, that's a lot, right? I mean, normally it's much less than 1% in the general population would have a recurrent event in their life. So it's definitely elevated, and the risk was lower in PSA. I think it was 3 or 4%. About half that had recurrent events. Certainly in other JAK programs, usually it's been kind of 3 to 5%, somewhere in that range, that have recurrent events, depending on the indication. Most of that's RA data. So it is interesting. I have come to believe that group that has recurrent events is just somehow different, and they are not building, when they have their event, they, for whatever reason, don't build protective immunity long-term from their event, versus, most people do. I don't know. I think, what we've seen in modeling some of the data from the other programs, and you were involved in some of those studies, we've seen prior zoster as a risk for later getting zoster once they've gone into a JAK inhibitor trial, or, started being exposed to a JAK inhibitor. And that would not be usual. Again, if you've had zoster before, probably you're protected for some time. But again, there is some subset of people who just don't seem to build immunity from that experience. So in most of these JAK programs now, yeah, it does seem like, if you've had zoster before and you're going to go on a JAK inhibitor, that is a risk factor. And that's someone I would think about certainly vaccinating before they go on to a JAK inhibitor, or really probably anything else. But it is part of the history, certainly.
So that's a good question. Does being on steroids, being on methotrexate, having diabetes, do they add appreciably to the risk in this analysis?
I think, yeah, there was a paper published last year from the Rabbit Registry that looked nicely across all biologics and JAKs, and certainly steroids was a huge risk factor. If you were on 10 milligrams or more steroids, the risk was just as great as it was independently with the JAK inhibitor. So there's no question that in my mind, concomitant steroids or steroids alone are risks. Now, as you know, and you're probably asking a question, some of the studies we've done together with other JAKs, we haven't seen concomitant steroids adding to the risk that we're seeing with the JAK inhibitor. Whereas we have seen that with tofacitinib and some other studies where there is kind of additive risk. So I don't know. I mean, I think there's something to the idea that if the one risk factor is so strong, if you add another risk factor to that risk factor, sometimes you don't really see much change because the initial risk factor is so strong, it kind of covers up your ability statistically to see much difference when you add another risk factor, particularly when you're underpowered. So I don't know. I don't know how to explain with like UPA, for example, why we didn't see steroids combined with UPA at more risk than UPA alone, but I don't know. We didn't. It's hard to believe that steroids don't add to the risk because every other study has shown that. And again, I think that the real world data would also suggest that as well.
And methotrexate?
In terms of real world data, we don't really see an increased risk. In terms of the JAK development programs that we've all been involved with, I mean, we haven't seen methotrexate really add to risk. We did initially in the TOFA program in RA, but we were, we just weren't really powered to be able to discern what the independent risk was. And once we were, we had enough person years of exposure, et cetera, methotrexate kind of washed out as something that was causing independent risk. And most of the additive risk we were seeing at that point was from the steroids. So I don't know. I mean, I certainly think JAKs are king when it comes to causing shingles, and steroids are probably of a similar risk if they're at a high enough dose. Once you're talking about doses of 5 and 2.5, the dose, the dose effect is real. The risk is much lower at those levels.
The other thing I noted from your paper that there was a lot of 45 to 65-year-olds. Was that just a numbers game, or do you think the risk because of their disease and therapy goes down to as young an age as 45? Our government will only give free vax to people over 70?
Yeah. I think they're going to have to change, of course, because the labels for the vaccines are changing, at least for Shingrix, and it has in Europe and the US, that, you can give it down to 18. There's kind of and it's recommended by now CDC to give it down to 18 in immunocompromised patients, with the big, asterisk saying there's very little data. No one's really studied it outside of a couple niche immunocompromised areas. So there's not much data in the world of rheumatology where we inhabit. Of course, you and I and others are working on that and trying to do some studies to better understand how best to use Shingrix in this setting. But I definitely think, if you look at this paper that was published, and if you look at other studies, patients with RA or certainly vasculitis and other things, they're at much higher risk, even down to the age of 20 to 30. I mean, their risk could be as high as your average 60-year-old who doesn't have those conditions. So, I think there's good rationale to offer vaccine to those younger cohorts if they have immunosuppressive diseases, or if they're using JAK inhibitors, for example.
Yeah, just to clarify, the TGA, which means you can prescribe it, anyone immunocompromised. It's only the reimbursement issue from the PBSE. So just to clarify that up. The other thing is a bit concerning. 7% had post-herpetic neuralgia, and of the zosters, 1 in 3 were severe. So, these guys didn't just have, most had mild to moderate, but there are patients who get stuck with post-herpetic and really have had a severe bout.
Yeah, I think that's worth noting. I mean, I guess in general, though, 7% is actually probably half of what it is in the general population. So there is this idea, Peter, that these drugs, while they may cause zoster, they're probably less likely to result in PHN. And I think this data would support that. But to your point, it's still 7%, and they could still have a pretty bad trip. So it does reinforce the need to try to prevent this. But I do think it's probably lower than what we see in the general population, where it's more like 10 to 15%. But what was interesting too is most of these patients they stayed on their tofa during this, and almost all of them, if I recall, were given antivirals too. So I think it speaks to the idea that you can manage these events by antivirals with or without temporary drug interruption with tofa or whatever JAK inhibitor you're talking about. But it's interesting. I think that's why we wanted to review this experience as well, just to see exactly how those meds were handled during the events, and to see if it seemed to make any difference. And it didn't seem to make a difference when we looked at people who stopped tofa versus didn't stop tofa, or used an antiviral or didn't. But of course, that's all retrospective data. You can't really answer those questions without a prospective study. But suffice it to say, it does elucidate at least or highlight how these cases were managed.
And I agree. You only had to change treatment in 9% of people in these studies. So the rest stopped for a couple of weeks, went back on and continued. So that's quite helpful to know. Also, the PSA guys, almost like half of the risk of everything that the RA people had, 1.8 per 100 patient years, also 0 vax, only 3% severe, 5% history of zoster. So PSA clearly a lesser risk.
Yeah, and I mean, obviously some of that was age driven. Some of it's probably driven by lesser concomitant immunosuppressive use. But definitely age plays a huge role there. So
yeah, so that sounds like what we should do is be aware, vaccinate if we can. What take-home messages would you like to give from this particular study?
Yeah, I mean, I think the take-home message is, similar to what we've concluded about JAKs in general. If you're going to put someone on a JAK, you ought to try to vaccinate them before you do it. And if you can't, do it after they've started the JAK inhibitor. And I hope to come back in a year to tell you how best to do that based on the results of our study and several others that are ongoing. But, I think another take-home message is that, you probably ought to put these patients on antiviral therapy that may or may not, but probably decreases the risk of PHN if you promptly start that. And that, as long as it's not serious, you probably don't have to discontinue the TOFA. So like I said, most of these cases weren't serious, and a lot of them didn't, the majority didn't discontinue their TOFA. I certainly advocate generally doing it if there's anything more than, a monodermatomal experience going on. Doing it, meaning I'd start antivirals and probably stop your TOFA for a few days. But clearly this experience suggests that for most cases, they're mild or moderate, and you don't have to do that. So, but again, antivirals were used in almost everyone. So, if you took antivirals out of the picture, how TOFA management in the context of an outbreak would make a difference, I don't really know.
Yeah, interesting. What do you think of Zostavax, the study that said it really wasn't particularly protective? I've given up on Zostavax and tried to talk everybody into Shingrix and give them a script for an antiviral to keep in their cupboard.
Yeah, I mean, certainly the patients I see clinically, this 3 to 8% that are having these recurrent events, I mean, those are people I put on. I either, say to the rheumatologist, hey, you should switch them to different medicine, or we should just put them on a suppressive antiviral therapy. So I give people 2 events, and if they've had 2, then I've decided they're not really protecting themselves. If they're going to stay on the JAK, I'll just put them on an antiviral. I mean, that's how I handle that group. As far as Zostavax, I think if I lived in a place that still had Zostavax, did not have shingles, I would use Zostavax. I do think it gives some probably short-term immune boost, but you'd have to, of course, you wouldn't want to use it when someone's actively on a JAK. You'd want to use it before they get on the JAK. And we did do a study showing it was safe to use with TNF blockers. So I think, for countries that don't have the Shingrix yet, it could still be a useful tool for the short term. And then once you get Shingrix, then of course you'd want to use that.
So thank you so much, Kevin, for your time. If you'd like to know more about this paper, I recommend you read it. It's very instructive about a common issue, puts things in perspective, and gives us some clear guidance on what we should do with our patients. Other papers uploaded to the CSF website this month. You can get detailed slide sets, are available in the publication section of cytokinesignaling.com. Please subscribe to this podcast on iTunes and other podcast media that you use, and give us some feedback and let us know what you think. Thanks very much for your time, Kevin. I'm going to let you get back to work.
You bet. It's great to see you, Peter, as always. Hope to meet up with you in 2022.
Copenhagen, EULAR. See you there.
You got it. Cheers.